divided into 10 fractions. Sometimes if you're going near the spine, you have to go even slower, or near sensitive tissues and make it 20-25 fractions. So that's the way you isolate your field. Recent studies now have been talking about single fraction radiation, and there have been a few studies that have done a comparison between single fraction and multi-fraction. And what they found is a single fraction of 8 grays is equivalent to a multi-fraction of 24 to 30 grays in efficacy and toxicity. It's much more convenient to the patient, but they can have a relapse of pain symptoms, and they might need re-irradiation, which is again effective if they get re-irradiated. So many people are now going back to single fraction irradiation. Post-operative radiotherapy is also useful to prevent loosening of your surgical hardware that you put in. And this was a study done by Townsend, which showed that 15% of patients who did not have radiotherapy after surgery had loosening, compared to 3% who had radiotherapy following surgery. Yeah, when you do sort of nailing like shown in Matt's presentation, you got to increase your radiation field to the whole bone, because you contaminate the rest of the bone with the tumor cells. In the spine, I know there's another talk of spine metastasis, but just briefly going through, mainly again pain. For pain, it's used in slowly progressive and mild neurological symptoms, in a radius-sensitive tumor, in multifocal lesions, and you can also use it if there's soft tissue compression of the canal rather than bony. Instability is a relative contraindication because it can increase the instability and collapse. Again, it's you increase the number of fractions in spine because of the cord, and use a wider margin. These are some new radiotherapies which I found. This is the image-guided intensify modulated radiation, and this was a very interesting intraoperative radiotherapy done by Japanese Taichi Kondo, where he sort of did an en bloc resection, a 360-degree decompression of the spine, covered it with a sterile drape, and sent the patient for radiotherapy, and then came back and closed the wound. So that was pretty intense here. So most of the radiation result, 90% of the patients had some pain relief, 54% had some relief. Most respond in about 2 weeks, but about 90% by 3 months. About 50 to 70% had pain relief for life. Though the symptoms improve pretty early, X-rays and scans take a few months to improve. Like this is a PET scan of a patient after lung cancer, radiation. That's after 4 months. You can see most of that lesion has resolved. The other thing is radioisotopes. These are very selectively taken up by the bone cells and the skeletal metastasis. It minimizes your radiation to normal tissue, and it's usually administered as a single dose in the outpatient. The limitations are you need a good renal function and good bone marrow reserve, which most of your cancer patients wouldn't have. The main toxicity is hematological toxicity with a drop in blood counts. So the commonly used isotopes are strontium-89 and all these. Iodine-131 we know with thyroid cancer. So with the use of these radioisotopes, now the hemibody radiation is more or less obsolete. Again, indications of a widespread bony mass. Complications of radiotherapy. There's acute and long-term complications, and the main thing we are worried about is skin complications, right from erythema right down to desquamation. If surgical fixation is indicated, it's better to give post-op. There have been studies that have done preoperative radiotherapy and have had a very significant wound breakdown rates. And if he has had previous radiotherapy, avoid incisions through that area. Other complications, irradiation increases your fracture risk. increases your risk of avascular necrosis and leading to stress fractures and non-unions. Other general complications, GIs, systemic side effects, chronic edema, fibrosis, and malignant transformation of irradiated tissues in the long term. Timing of radiotherapy, usually 2 to 3 weeks to let the wound heal. Systemic anti-tumor therapy, for this it's important to know what kind of a tumor it is. Most of the chemotherapy is resistant in renal cell carcinoma, and, but it can be curative in lymphoma and germ cell tumors. So most of this cytotoxic therapy is directed by an oncologist. Hormonal therapy is very, I'm saying 50% of breast cancers respond to hormonal therapy, and about 70 to 80% of prostate cancers. Most of the chemotherapies are combination. So when we're giving chemotherapy, you take into account the patient's age, functional status, nutritional status, and most of it is combination chemotherapy. You give a combination of drugs, cytotoxic drugs, and you give them in cycles. This allows you to, for the bone marrow and the tissues to recover. Common side effects, again we know nausea, vomiting, myelosuppression, diarrhea, and mucositis. So in breast cancer, as we've talked, hormonal therapy is highly sensitive. In multiple myeloma, give a high dose chemotherapy with some bone marrow and peripheral blood stem cell supports. Prostate cancer, we give a total androgen blockade, that is LHRH and anti-androgens. The thing that we use nowadays is bisphosphonates also. This has been shown to reduce the number of metastatic bone lesions. It slows the osteoclastic activity, so it slows the metastatic lesion, decreases the number of lesions, decreases the pain, and your risk of pathological fracture. It also reduces your need for radiotherapy. So this is basically, they have this PCP structure which is taken up by the osteoclast and cause osteoclast apoptosis. The commonly used in bone mets are clodronate, which is an oral medication. Pomidronate is IV, 60 milligram, and zolendronate, which is another IV medication. Very useful in controlling your hypercalcemia with metastasis. Useful in reducing your bone pain. It delays your skeletal related events, which is basically your fractures, pain, and it's also been shown to improve your long-term survival. So these are some of the studies that have been done on bisphosphonates, and most of them have shown that there's a delay in the first skeletal related events, and also reduces the amount of pain that the patient gets. There's a good journal in JAOS on bisphosphonates in 2003, which I've got most of this from. Again, starting your adjuvant therapy is 2 to 3 weeks after your surgery to help wounds heal. Ashford and all said that if you put a sort of tumor endoprosthesis, if you're giving chemotherapy, or adjuvant therapy, it gives 6 weeks of antibiotics post-op, just to prevent any immunocompromise in the patient. Well, so thank you.
We're at a short break, about 15 minutes, and we'll come back and do the final session.
Just a reminder, guys, hospital vote tomorrow is 1:15 and rehab, so 2 to 5, 2.5 hours.